Welcome to Raaonline. So today we are going to see one of the very important trial. Any branch of medicine, let it be especially emergency medicine. If you're going for an exam, cardiac arrest is going to be a sure shot case, especially in your viva, right? So there comes your post cardiac arrest management also, post RAC management also. There, what is the temperature you will maintain? This is called as a temperature management system or targeted temperature management. Okay. So why should we actually think of a temperature management in a post cardiac arrest care? The basic background is there were two previous studies which has proved that this kind of temperature management, especially hypothermia, has benefited as far as the mortality is concerned. So we are going to check whether really a targeted temperature management is going to be favorable in our set of population. Okay. So this is a TTM trial, targeted temperature management at 33 degrees Celsius versus 36 degrees Celsius after cardiac arrest. So this was published in NEJM in 2013. So the clinical question being, in adults that suffer an out-of-hospital cardiac arrest of presumed cardiac cause, does induced therapeutic hypothermia targeting 36 degrees Celsius compared to 33 degrees Celsius reduce mortality or reduce neurological deficit? So the idea is, can I maintain my patient's temperature to 33 degrees Celsius itself? Will it benefit as far as mortality or the neurological deficit is concerned? Okay. So design. It's a randomized controlled trial and it's a single blinded design. Settings, it's conducted in 36 intensive care units in Europe or Australia and especially in November 2010 to January 2013. So you need to be very careful when you are identifying these kind of trials. This is out of hospital situation only, out of hospital cardiac arrest only, and it's presumed to be only cardiac cause, only cardiac cause. Okay, so this is where we are coming across by each slide. So this does not include the in-hospital cardiac arrest patients, and this does not include a cardiac arrest because of any other or maybe like a non-cardiac causes. Okay. So the population under study is the adult patients who are unconscious, that is GCS less than 8 on admission to hospital after the out-of-hospital cardiac arrest of presumed cardiac cause, who are all excluded if it's more than 4 hours from RAC to enrollment screening, okay, or witnessed arrest with asystole, hypothermia already, that is less than 30 degrees Celsius, or suspected or known intracranial hemorrhage. So all these group were excluded, and totally we got 950 patients who got enrolled in the study. So this is the basic baseline characteristics of each group. This is 33 degrees Celsius group and this is 36 degrees Celsius group. You can see that age is well matched, 64 plus or minus 12 in each group, roughly around that scale, and male 6 is also around 80 plus or minus 3, and chronic heart failure is almost the same, and previous atrial MI ischemic heart disease is relatively comparable, and the localization of vessels and location of cardiac arrest almost are matching. So if you want to have a deeper look into it, you can freeze this slide and see each one. And the time from cardiac arrest to the event, that is from starting of the basic life support, is almost same in both the groups, and start of advanced life support is also equivalently stable. So these things matter a lot. So at the earliest of BLS and as early as ACLS is started, they have better prognostication values, and those things are very comparable in each of these groups. So now we have an adult patient with the out of hospital cardiac arrest presumed to be a cardiac cause, and we have excluded by few of the exclusion criteria, right? The patient should not have any other non-cardiac causes, especially intracranial hemorrhages, and he is not hypothermic less than 30 degrees Celsius, and it's not more than 4 hours. So we have excluded certain exclusion criteria, and now we have this patient. So what kind of intervention are we going to do? We know that it's going to be a single blinded study, right? So what is the meaning of single blinded study? A double blinded means both the caretaker and the patient and the family doesn't know what type of intervention are they going to receive. Are they in the intervention arm or are they in the control arm? If it's going to be single blinded, it's only one party who is not aware about what intervention these patients are undergoing. Okay. So in this category, where the staff nurse is there going to be with the patient who is going to measure the temperature, it's going to be obviously difficult to blind it, right? because they know what's the temperature of the patient, right? So it's going to be a single blinded study. So 28 hours of temperature management with a target of 36 degrees using an invasive or surface cooling, followed by gradual warming to 37 degrees Celsius at 0.5 degrees Celsius per hour. So you need to be very careful when you're practicing hypothermic management. You need to rewarm slowly at a point of 0.5 degrees Celsius per hour after your hypothermic management, and avoid hyperpyrexia up to 72 hours from the time of randomization. Okay. So 4 patients did not receive this intervention as assigned because of various other reasons. So again, in control group, there's 28 hours of temperature management with the target of 33 degrees Celsius using invasive or surface cooling, followed by the same gradual rewarming to 37 degrees Celsius at 0.5 degrees Celsius per hour, and avoidance of pyrexia for 72 hours from randomization, and 3 patients did not receive this control as assigned.